So we'll start with a recent case we had. It's a 31-year-old gentleman who showed up in a hospital with acute myocardial infarction, which he himself hadn't suspected. So went to the hospital 2 days later, and by the time he had pretty badly damaged myocardium. They had tried to do angioplasty, but I don't think that did much good to him. Then he was sent to us in shock. At that point, we went on to put him on a VA ECMO centrally with a LV vent. Now, he was on the favorite poisons which cardiologists like to use, which we don't like. And that information was withheld from me so that I will go ahead and do a central ECMO. And anyway, after the ECMO, he was okay, but he kept bleeding and had multiple re-explorations as expected. A few days later, since he was not going to be fit for a transplant soon, we decided to move him to a Centrimac. In that time, he developed mediastinitis and had active fungal blood infection. Now you're stuck with a patient who's on a device which you cannot remove, and organs are recovering, but he still has signs of infection. We just went ahead and did a transplant as we got a heart, and he left the hospital. It's been about 3-4 months. He still remains on antifungals, which he probably will for his lifetime. The thing is, things like this can be done with the advanced support devices we have, but the amount of money you spend on these are phenomenally high. So sometimes I wonder if it is better to just use an LVAD instead of waiting on somebody like this for 3 months and then doing a transplant. At the end, the cost sort of equalizes. When you look at the data on acute cardiogenic shock, either from decompensated heart failure or from acute MI, the native heart survival is only 30%. If you want to look at the total mortality, it is nearly 60%. If you see in the recent years, the mortality has improved from what used to be 50% to a little less than that. It is because we are doing more and more of replacement therapy, either by way of transplantation in an acute setting or by doing a durable device in an acute setting. What has intrigued me in devices is one case which was reported first from Toronto, where they had increasing sepsis from the lung. They went ahead and did a bilateral pneumonectomy, maintained the patient on ECMO, and once the infection cleared, since the lung was the source of the infection cleared fairly quickly, and they were able to do a transplant. Another unit also reported a similar system where they have used a different configuration. They stitched the PA to the left upper pulmonary vein in order to keep the heart from clotting. This patient also had a transplant subsequently. Now, in cardiogenic shock, we know we've had various classifications. The standard one from NYHA, then we have the ACC-AHA classes. And when you look at the stage 4 or the stage D, which they're all pretty much the same, you cannot make a uniform therapeutic decision in this. So Intermax came subdividing them into further categories where you have levels 1 through 7, the higher levels being more acute. And when you are in the level 1 or level 2, they need urgent attention by way of temporary device, usually. So again, the higher levels got subdivided further by the SKY classification into A through E, with people who have hypoperfusion starting at C, going down further. Now, why do we need to use a temporary device in shock? The whole idea is to prevent multi-organ dysfunction, which tends to set in very quickly. Now, one should remember that there is microcirculation, there is macrocirculation. Whatever we can do, we are only addressing the macrocirculation. At some point, there is a dissociation between the micro and macrocirculation. After that happens, whatever device or whatever therapy you do, you are not going to improve end-organ perfusion, because you can only address the macrocirculation and it will not translate into microcirculation at all. So a rising lactate after you have re-established good flow is an indicator that your prognosis is going to be poor. I'm not talking immediately after establishing circulation. If it is still going up 6 to 8 hours after, the chance of recovery is going to be much lower. And the more ionotropes you are using, the worse the prognosis will be. So if you need a lot of vasoactive drugs, there is really no need to wait till your toes turn blue before you start looking at some kind of mechanical circulation. Mechanical circulation is good for tissue perfusion without all these deleterious effects of these drugs, and also it improves myocardial perfusion also by reducing the intramyocardial tension. The data shows that the more number of drugs you use, the mortality gets worse. And it's also important that you use continuous output pulmonary artery catheter in order to monitor patients who are in shock. And it has been shown that if you use a pulmonary artery catheter within 6 hours of admission, there is a remarkable improvement in the outcomes. And also, it is important to monitor all the parameters on the pulmonary artery catheter, including online SVO2, in order to reap the benefit of it. If you do not monitor all the parameters, it is as much as not having a PA catheter. IABP, is the earliest of the mechanical devices, and yet and still the most popular one. Whatever the data shows, that is the first thing everybody likes to put. So we have found a renewed interest in patients who have got chronic heart failure, who come acutely compensated or even otherwise. In these patients, the SVR is extremely high, and the patients who've got MR and high SVR tend to do much better with IABP. An ambulatory form was developed, but it really never came to the market. Impella is the hot favorite as of today. You have various avatars of it, and 5.5 is yet not available in the country. Maybe once that is available to us, it might be something which can improve the outcomes in shock. Everyone's familiar with the pump, but in the recent past, a lot of data on shock has shown improvement in the outcome because the use of Impella, either along with ECMO or by itself, has increased a lot. Impella is available for the right side as well. You can see in the recent danger trial, they have shown an improved outcome with Impella in cardiogenic shock patients in acute MI. That's a subset which did not have a very good outcome. Centrimag is still one of my favorite pumps because it is very versatile. It can be used on the left side, right side, biventricular configuration with an oxygenator as ECMO. And when the need for lung support is over, you can remove the oxygenator from the circuit. The only thing to remember is when you have an oxygenator on a bivat circuit with the oxygenator on the left side, if you're going to remove the oxygenator by clamping the left side, make sure you clamp the right also. Because if you have a LV that is not working and you're pumping blood into the lungs and you've clamped the line here, you will instantly die of pulmonary hemorrhage. So you must stop the circulation entirely for that moment of time. Of all the devices, Centrimag is the one which can provide you 5 to 10 liters of flow. And everyone says that the biggest disadvantage is you need a surgeon. Which hospital does heart failure without a surgeon there? Everywhere there is a surgeon, and all surgeons can easily put this. It's not really a difficult procedure. This is a schematic of how the Impella works. You have a rotor which is magnetically levitated, so it doesn't cause much damage to the formed elements of the blood. So when we use it in a biventricular configuration, this is what we do. We have a cannula in the right atrium that drains and delivers back into the PA, and another one which is in the left ventricular apex as shown there, or in the LA. I used to do LA before, now I do LV apex mostly. That goes back into the aorta. And you bring out all the cannulas, you close the chest and you mobilize them. They can be on this for months. So we obviously cannot afford to be using durable VADs as bridge to transplant. So there are patients in Bangalore, not in our center, who've stayed on this for 8 months on biventricular configuration. They do tend to develop some antibodies. You may have to desensitize them. We can always add an oxygenator if required. And there is this other concept called COGI-VAD, where most people who come with an acute problem will need biventricular support. So he's used a graft in the axillary artery for return with an oxygenator in the circuit, and you drain from LV apex with a thoracotomy and a femoral vein. And once the right ventricle recovers, you remove the femoral venous cannula, and once the lung recovers, you remove the oxygenator. So it becomes a pure LVAD. And you can bridge them to transplant with that LVAD, and the sternum is not open, so it's not a redo sternotomy at that point of time. ECMO is normally our go-to strategy for anything. You don't have to think much. In our institution, the standard is put 3 cannulas, RA, aorta, and LV apex, so that you don't have to think about it. You don't have to worry about differential perfusion. You don't have to worry about LV drainage. So you start with that, and whoever is on call can do this. All cardiac surgeons can easily put this. And one should remember that the whole idea is to re-establish the normal oxygen delivery and consumption ratio. So if you're putting an ECMO and providing 1.5 liters flow, you're not going to meet that objective. You must be able to get adequate flows to meet this objective, and also to reduce the filling pressures in both the ventricles. Only then ECMO is going to be a useful thing. So a lot of these situations is much better to use central cannulation, because peripheral cannula in a patient who has come on a few kilograms per kilogram of noradrenaline to you will be extremely small, and you will not be able to establish much flow through the femoral artery. And it is extremely important to unload the left ventricle. There are so many different ways you can do that. The obvious and bad way is to reduce the ECMO flow. You can drain the LA or drain the LV apex, or if you're doing peripherally, you can put a cannula across the interatrial septum into the LA. So it will drain the LA from the tip, and side holes will drain the RA, and it will provide good flows as well. So if you need to look at it from percutaneous point of view, it is important to make sure that there is no stasis in the LV. Otherwise, regardless of what ACT you maintain, the LV will clot. This is a picture of how the cannula is placed across the interatrial septum, and you can see in the lower picture that it is sort of looking like it is outside the heart. It is because it's sitting in a pulmonary vein. And another way of using unloading is with Impella. This is probably one place where Impella 2.5 is useful. All the other places, if you're going to use Impella 2.5 as a single device, it is not going to provide adequate support to the circulation. Post-cardiotomy, cardiogenic shock is a surgeon's nightmare. ECMO is usually the solution. We do central ECMO, but mortality is extremely high in this situation. A lot of times after a durable device, durable left ventricular assist device, the RV fails, and then we use temporary right ventricular support. General configuration is to stitch a graft to the PA, bring it out, and use that for return, and use a femoral venous cannula for drainage. And once the RV recovers, you can remove it without returning to the theater. One thing you must remember when you're dealing with pure pulmonary hypertension and RV failure, if you're using an RVAD in that system, if you were to provide high flows into a pulmonary artery which is hypertensive, you're going to cause severe pulmonary hemorrhage. So you must avoid using an RVAD in right heart failure which is due to pulmonary hypertension. ECMO is also used as bridge to transplant in VV configuration when we are dealing with pulmonary failure as well. We heard about heart transplantation extensively. We would use ECMO as bridge to heart transplant sometimes, and also when there is graft dysfunction. And same thing goes with lung transplantation and heart-lung transplantation, either to deal with graft dysfunction or bridging them to the procedure. So this is the picture how we do the VAD for a we support the right side in a durable VAD. So in conclusion, temporary MCS is expensive. When we were students, we thought IABP is expensive. Now we think Central Mag is expensive, but certainly it is not as expensive as life. So the main thing I want to say is that instituting these early is the key.